to serve as your moderator this afternoon for the session entitled Data-Driven Solutions to Improve Access to Care. What you measure is a value statement, and this sentiment is one that was expressed by two of my mentors in the equity field, Daniel Dawes and Dr. Joa Perry. But it's really also underpins what we're here to discuss today. What do we measure, and does it reflect the things that we say we value in terms of healthcare? COVID has expressed and exposed so many things that minority-serving organizations and minority-focused organizations and researchers have known for years, but it's the clarity through which COVID has shown us that the U.S. healthcare system simply struggles to find its way in terms of ensuring equity for folks in terms of coverage, access, and quality. So nothing, I think, has shown us how greater the stakes are than the time of now, and that we need solutions at every level possible, all hands on deck, if you will. But to ensure that we have a good allocation of resources, we have folks operating in their gifts, we have organizations operating in their gifts, how do we measure that? How do we quantify the need? How do we determine where things go? How do we identify where things need to be? How do we determine and identify the places where things can shift and be retooled because we've gotten success in one place and can turn our efforts to something else? So that's why we're here to talk about data, and we have some wonderful panelists to do that and to guide us through that discussion. One of which is experiencing a bit of technical difficulties, but we do hope that she's able to join us. And so I'll just introduce them briefly, and then we'll turn and let them have their opening comments. The first is Courtney Christian. She's the Senior Director of Policy and Research at Pharma. We also have Chris Parkin, who's the President of CG Parkin Communications Incorporated. Christopher Cox, who is the Senior Policy Advisor for U.S. Congresswoman Yvette Clarke, and Sharon Thomas, who is the Program Director of Health Equity and Social Determinants of Health for Aetna, a CVS health company. Now, I just want to give you a couple of programming notes. Please wait until the Q&A portion to ask your questions. In case there are initial questions, you can put those in the Q&A box. And I emphasize the Q&A box and not the chat box because we want to make sure that we catch all the questions amid all the chatter that we may experience. So with that, I'm very pleased to turn to Courtney Christian, Senior Director of Policy and Research with Pharma, for her comments.
Thank you, Ariel. It's nice to be here with you all today. I represent Pharma, which represents over 30 of the leading biopharmaceutical companies who are really invested in treatments and cures that help patients live longer, healthier, and more productive lives. And as you stated earlier, COVID-19 has really served to lay bare, the long-standing gaps in access to healthcare that are heavily impacted by social determinants of health, where we work, where our kids play, and too often where we live, our zip code. This pandemic has really, made that even more glaring that, as one might expect, areas where there's high access to care, to greater economic opportunity and resources that, improve health outcomes, they're fairly good. But in the areas where there are not those access points, the health outcomes suffer. We know that, chronic disease affects Americans greatly. Nearly 200 million Americans have at least one chronic disease, 75 million more have more, and the health impact and cost to the system is even greater. So we really need to be thoughtful about the data points along the way that we can help overcome some of these health outcomes and improve them. And we also, are really thinking more broadly at Pharma about chronic disease and prevention, because that's a little bit of our wheelhouse, right? Disease states, in urban and rural settings, but we're also thinking about the value of healthcare, identifying the impact of systemic barriers to care, and then really thinking about the data and information technology systems and structures that really play into conducting value assessments in underrepresented populations.
Thank you, Courtney. And we'll turn next to Chris Parkin, President of CG Parkin Communications Incorporated.
Okay, thank you very much, and thank you all for being with us today. I'm in kind of a unique position. My role in all of this is I do a diabetes research for the pharma and device companies. And so I'm kind of the bridge between, using the technology that allows us to identify where the resources are needed, and then how we can get that technology into the hands of patients. And I think what I would like to start with, I'm going to share a screen if everyone's okay with that. This is from a paper that just went online, I think last week. We had a meeting in Madrid last February before COVID, or actually went the very beginning of it, of about 75 or 80 representatives from the pharma and device companies to look at how do we use technology to connect patients with physicians, and allowing them to go back and forth with meaningful, actionable data. And what this diagram looks at, we use continuous glucose monitoring, which is one of the newer technologies out there that allows people with diabetes to have a constant flow of information about their glucose levels. And the device is sent through a smartphone. It goes through middleware, comes in through electronic health records, or it comes directly to the physician through a portal that allows the physician to look at the data that the patient is actually looking at as well. So it's one of those things where we now have got the technology to truly connect patients and clinicians in real time with meaningful information. And I think, when we're looking at COVID right now, the only upside that I can see is that it has really laid bare the potential.
Okay, I just did that. It says unmute.
Or am I okay?
Yes, continue, Chris.
It's really laid bare the potential as to how telemedicine can actually be used. And we're starting to see some of the regulatory agencies, as well as some of the private insurers, recognizing the benefits of telemedicine, particularly in chronic disease. I mean, as we look at COVID as an acute disorder, an acute disease, it's managed to really bring to a standstill regular clinician visits between patients with a chronic disease and their clinicians. And telemedicine bridges that gap. And I'm glad to see that more and more people are appreciating that. The problem that we run into is getting the technology to the patient and getting the clinician to actually use that technology. And I think that's where we come back to our discussions today, is to how can patients access this technology? And I've got a paper under review right now that looked at Medicare data to look at how many people actually adopted CGM during the first 6 months that CMS was covering CGM. And we uncovered some real, just kind of alarming racial and ethnic disparities in terms of the percentages of Blacks and Hispanics who were using this technology compared to whites. So that was a red flag to us. So I guess, my role in life right now is not only figuring out how to help people use the technology to close this circle, but how do we create an environment that allows patients with a chronic illness like diabetes to access the technology? What are the barriers to their access? And does that involve, is this patient-centric, or do we need to include the entire healthcare team in overcoming those obstacles? So I'll just kind of let it all go from there. And I'm looking forward to a very nice Q&A discussion later on. So thank you very much.
Thank you. And I believe, Sharon, are you ready? If you're ready, okay, so we next have Sharon Thomas, who is the Program Director for Health Equity and Social Determinants of Health for Aetna, a CVS health company. And I think her tech issues have resolved themselves. So fingers crossed. Sharon, take it away. I can't hear you, so we'll just give them a second to work on your audio. And we'll actually pivot to Christopher Cox. Are you ready, Christopher?
Yes, can you hear me,
Christopher
Oriel?
Cox. Yes, Christopher Cox is the Senior Policy Advisor for U.S. Congresswoman Yvette Clarke. So, Christopher, thank you, and take it away.
Thank you, Oriel. First, I'd like to thank the National Minority Quality Forum for inviting me to participate today. It's a pleasure, and I want to thank you for Oriel for moderating today. As she said, I'm the Senior Policy Advisor to Congresswoman Yvette D. Clarke, who represents New York, Brooklyn to be exact. I'm really excited to be here today to have this conversation because we do need to kind of focus on like data solutions to give us like access to care. I have the privilege to handle the Congresswoman's healthcare portfolio and tech portfolio. So it's really important that I'm here today. And I think the Chris's are handling the health and tech spaces today. So I'm excited about that. In the healthcare front, as we talked about earlier, the coronavirus pandemic has really revealed a lot of disparities to America that we've known a lot, we've talked about in the healthcare space, but I think that, we cannot deny what's been going on in the space today. And I'm really excited to have the opportunity to help push forward the Congresswoman's agenda and her legislation to ensure that we get the people across the country what they need in their time of need. In my role as the tech policy advisor in the office as well, I also am aware that a lot of us are working from home, a lot of us are learning from home, and a lot of us are getting our healthcare from home right now. So in the tech space, it's very important that we also kind of speak to that intersection as well. I know a lot in the healthcare industry, we have conversations around the barriers to care being access and affordability. And I can say in the tech space as well, we face some similar challenges, especially in communities of color and other disadvantaged communities, because, we need the American people to be connected to the internet. We need them to have connections to their healthcare providers, and we need them to afford, broadband and internet, and we need them to afford their healthcare. So I'm very excited to kind of be able to speak to those intersections today. And I really look forward to the conversations we'll have, the presentations from the other panelists, and also the questions from you all out there. So thank you, Oriel. I appreciate it.
And thank you, Christopher, and thank you for standing in the gap there and coming out of turn. Sharon Thomas with Aetna CVS Company, we're ready for you.
Hi, can you hear me, Rel? Hi, sorry about that. So, hi everyone, I'm glad to be here. And again, my name is Sharon Thomas and I'm representing CVS Aetna. And I'm glad to be a part of the panel today. And I'm gonna talk to you guys, again about data. And as, I guess we're just sharing a little bit about our background. I am the Program Director for Health Equity and Social Determinants of Health. And, and so I focus on, chronic diseases and disparities from a health care standpoint. And, within that space, just looking at disparities and how members within care are treated differently. And it's been really, especially, trying amongst this pandemic. People have been, as we all know, care has been even exacerbated even more so. And so amongst COVID, we want people to still pay attention to their preventive care, but, COVID has also exacerbated care as well. And so I think as we are talking today, I'm hoping that folks in our community, as well as, in the community that we're talking to today, as well as those outside of this forum will realize that COVID exists, the disparities exist, but we need to also remember that our preventive care also needs to, we need to continue to think about that as well. So, and I'm hoping that we'll talk more about that.
Okay, so thanks to all of you for those opening comments. And I think we could probably have this session for a number of hours today, but we only have a defined set of minutes to get this conversation going. And so I'm going to try to hit the high points and maybe, have a couple of combo questions for you all to respond to. The first being, though, I think from the perspective of Mr. Cox and his role on the Hill, which I'm not here in that stead today, so I'm going to defer to him. But it would, I think, be a good opening salvo to talk a little bit about the things that you're hearing addressed as a congressional staffer from the standpoint and vantage point of equity, given your role also in coordinating the working group around health disparities that the Energy and Commerce Committee started. And then from your, I guess, the fertile ground of your possibilities, I would like to also hear some counterpoints from our other panelists about things that you didn't say that they think, for example, we should be thinking about on the Hill.
Ariel, thank you for that question. It's really important to talk about, this working group that you kind of mentioned. We've been having a lot of conversations across the Hill as staffers, really to explore ways we can kind of take this pandemic and really move forward the needle, the conversations around health disparities and the conversations around disparities in general. As the pandemic began to unfold, it was hard to miss a lot of the misinformation that was out there about how the COVID-19 pandemic was impacting and transmitted to the Black community. I saw on social media that, Black people couldn't catch this, virus. And, a lot of that misinformation really spurred up a lot of conversations, but that quickly shifted into discussions how the virus has really ravaged, communities of color, the Black community and the Latinx communities. But, 2020 has been a beast, to say the least. And, after the murders of Breonna Taylor and George Floyd, it sparked a lot of outrage across the country. And it gave rise to a lot of questions about how these compounding pandemics of COVID-19 and racism are really impacting, us as a nation. So in the initial months of the pandemic, Congresswoman Clark and Congresswoman Robin Kelly of Illinois created an informal working group really to address the racial disparities across the jurisdiction of the Energy and Commerce Committee. This group kind of touches on environment and climate change, energy, communications, technology, and healthcare policy issues. And due to the current pandemic, a lot of our work has really been centered around the health disparities, given the disproportionate impact of COVID-19 across the country. The goal of the working group, to kind of answer your question, is to diminish the impact of racial disparities across the policy areas I previously mentioned. Through a lot of the members' collaborative efforts, we are really working to create a targeted slate of data-driven legislative strategies. We were really leaning on some of our partners, on the Hill and off the Hill to really help bring in a lot of the information that we need to make sure that any legislation that comes out of my boss's office is data-driven. So that's very important. And we're also ensuring that we are holding the administration accountable for, their work on equitable responses. And the work of the working group will kind of continue. It's starting in the 116th Congress. We're looking to move it forward into the 117th, as we go get closer to January. And we hope to continue working with partners to address disparity issues across the jurisdiction. But our main focus right now is to really ensure that we bring a lot of thought leaders to the table to help us craft this legislation so we can make sure that we're presenting legislation that will be able to help the American people. So I'm really excited to continue this work as the coordinator of the working group under the leadership of both Congresswoman Clark and Kelly.
And with that, I guess with that side, I'll also just note and give a plug here for the work of the Ways and Means Committee around health equity from the vantage point initially of the Rural and Underserved Communities Health Task Force. And, that committee, the committee that I work for, we are very much so concerned about Medicare specifically. And so one of the things that I think in thinking through how policymakers at the federal level might need to think about these issues, I thought it would be interesting for Courtney and Chris to talk a little bit about the dynamic that they have and the different perspectives around a shared issue of diabetes as one exemplar of chronic disease burden in this country. Courtney has experience from seeing it overlaid with a couple of other concerning things, and I think Chris has shown that there's some disparity in access to some of the interventions that have the better outcomes that are concerning to him. And so I think it would just be interesting to hear from both of you around that, and then we could talk about some of the things that may be falling through the cracks in terms of those things that aren't sinking.
Sure, Oriel, I'll go first. I really like hearing about this working group on the Hill because at Pharma, we're doing sort of the same thinking along the same lines. We established a health equity roundtable a couple of years ago, really looking at some of the same issues you are, thinking about how we can improve health outcomes and addressing inequalities of care. Just this April, once we saw the outsized impact of COVID-19 in Black and Brown communities and, sort of this confluence of the racial unrest issues that are going on that everybody is now having to pay attention to. We thought about what we could do in this space and how we could best use our resources. So we issued a grant challenge to open to anybody. We ended up awarding 4 grantees and asked them to think about practical solutions to address disparities in treatment of chronic diseases among communities of color that we have seen are exacerbated by COVID-19. But we also did some other work building off a previous study that we had done before, looking at preventable diabetes-related amputations within New York, within your purview, Chris. And so what we found with this paper, was really alarming. We went back and looked at it once COVID-19 became the issue that it did, and we did some work in overlaying the data on the amount of diabetic amputations within New York. When we overlaid the COVID data, we found that the same places where there was a huge amount of diabetic amputation was where the same places where there was the most COVID-19 impact. And so it really makes us think a little bit more about how we can do more for prevention on the front end so that another pandemic like this doesn't really, lay bare the sort of chronic disease issues that disproportionately impact our community. And so there's a need there, I think, for some of the technology-driven solutions that I think Chris is working on now that he showed a little bit earlier that could probably really pair well with some of the work that we're doing on the ground, both at the policy level, but as in the corporate space too at Pharma.
Okay. I think we're working hand in glove here, my dear. The work that I've been doing and have been doing for about 35 years in the area of diabetes research is looking at an intervention and determining whether and to what degree it improves outcomes. And I think, I keep coming back to the CGM analogy. It's the newest technology out there. And we've shown that it works. Okay, we have great outcomes. It works when people use it. And I think that, what I'm kind of looking at right now is we know that it works, but we know that a lot of people are not using it. And we're trying to get now to the question as to why. What are the obstacles to it? And I guess in my opinion, what I'm seeing is there are really kind of 2 areas that I think need to be explored. The access based on eligibility to get the technology, to get it paid for, is one issue. But then the other issue, which I think is just much murkier, but I think much more of an underlying issue that we all need to look at, and I'm sure everyone here has been looking at it, that's why we're here today, is this technology even offered? And I think that's, I think there's a combination of that going on, so that if you look at, yes, we can use the data to identify where the resources are needed, but I think that we also need to really look at even the resources that are there. Are they really providing the care? Are they aware of this technology? Do they have assumptions about whether or not there are patients of color can actually use the technology. I mean, these are the types of issues that have not really been teased out. And I think that that's where, you know, to me, that's where I would like to start looking right now. I know the CGM works. I just don't know why more people aren't using it. I got some real strong suspicions, but I think that right now we need to address both of those aspects. When we look at CMS, for example, one of the issues that we run into is eligibility, and a lot of the insurance companies too. There has to be a history of at least 4 finger stick tests per day in order to be eligible for CGM. Well, what I find somewhat confusing is the fact that CMS only pays for 3 finger sticks a day. And so if somebody is in a lower socioeconomic status, they got to pick up the tab for an extra finger stick a day in order to be eligible for a technology that actually does a better job than 4 finger sticks a day. So there's a disconnect there. And I think, Chris, I'd like to talk with you offline at some point about that. And again, I've got a paper under review that points that out. And, you know, and again, what really confuses me is that a 4 finger stick per day history is totally unfounded in the literature. There's absolutely no medical reason I have yet to find. And in fact, I found recent studies on CGM that said it really doesn't make any difference at all how frequently you've been testing before you use CGM. You get the same good outcome if it's offered to you and if you use it. But you also need to look at it from the standpoint of, do clinicians know what to do with the data? Are they willing to work with the patient on this? So that's, I mean, this is kind of a hairy ball here that we're looking at. But I think, you know, to go into the issue of prevention, which to your point, I've been following the whole COVID. Where's the most devastating? It's in communities of color. I've been following diabetes has been most devastating in communities of color. And it all comes back to a good friend of mine, psychologist in diabetes, is that diabetes doesn't cause complications. Uncontrolled diabetes causes the complications. And that it can be, you can prevent these complications if people learn and are supported in taking preventative measures in their lifestyle, in exercising, reminders to take their blood pressure medication, their lipid medication, those types of things, which strikes me. I mean, it's pretty obvious to me. I can't definitively say it, but I'll bet you that kind of support is not being provided in these communities. So, you know, I guess that's all of our task here, is to figure out a way to start addressing this hairy ball that's just so intermeshed, but it's costing this country billions. And more importantly, it's costing us millions of lives. And that just, there's no reason for that. Not in this day and age, not with the technology we have available, not with the medications we have available. There's no excuse for what's going on right now. And it really does need to stop. So I'll get off my soapbox, sorry.
I think we all share that soapbox. Sharon, you want to add something?
Yes, you know, but to your point around when we talked about even COVID, you know, we go back to the earlier conversations around COVID and the information that was coming out there, you know, and the data that's even being collected. You know, the question I think is, you know, first of all, we wanted everyone to collect data by race and ethnicity and all of that, right? But then we also, when we look and saw that a lot of, you know, Black and brown folks were being, you know, impacted greatly, we want to also know what comorbidities did they have so that we could really focus on, well, what's contributing to them? Is it really inflammation? You know, is it really diabetes? So then we could really hone in, and I don't know that anybody's really collecting that so that we could later go back and study that, you know, when we say collecting it, you know, as a whole, right? So I think, you know, we'll look at this, you know, 6 months, 12 months down the line, and will we really have that kind of data that we can study and say, well, that'll help us? Because as we see, even, you know, things that are, you know, things are still changing. The symptoms are still changing, right? So I think that's one thing. And then the other thing I wanted to add to, Chris, what you were saying about your work group, you know, there are barriers that are out there. And I wanted to ask, as we talk about social determinants, you know, there was a bill, I think, that was out there around advancing ICD codes for social determinants. And I was wondering if that has been pulled in, or is that going to even be something that's part of the work group that you all are considering?
Thank you for that question. I think that it's a very important bill for the work group to consider. You know, we're trying to meet with a lot of our thought partners to kind of get those kind of pieces of legislation that, in your perspective, in your line of work, that you feel that would be helpful for the work group. These are conversations we need to have. And, you know, and I know from one of my first jobs out of my master's program was working for FQHC. And I know some of those codes are like, we really need to kind of think about those like deeper, because there's a lot of barriers in those conversations. But this is something I think that is very important that we need to kind of address. And I appreciate you kind of flagging that bill for us. And I will make sure that the members of the work group are aware.
I think it's Senator Bustos that has that bill.
So I think picking up from there and trying not to get too technical in a panel about data, but still being technical enough for the wonks among us, it seems that we're talking about a few, at least, different things here. We're talking about patient data, both what we know about people when they come into the system and what happens to them once they encounter an interface with the system. And then we're talking about the system itself, both the data about its capacity on the front end, and then how that capacity contributes to cost and outcomes, I think, on the back end. But then also there seems to be that unnamed something in this conversation that we need in the United States to really be able to figure out why we see the same type of disparity with diabetes burden as we see with COVID. And I think if, you know, the folks who are interested in this space are familiar with the IMPACT Act. The IMPACT Act directed the HHS, the Centers for Medicare and Medicaid Services, ARC, to do some reports looking at all of these different factors about how we look at social determinants in healthcare payments specifically. But recognizing that social determinants are really the driver of health costs, but the unknown confounding factor of healthcare outcomes, because they don't come out of healthcare. They aren't controlled by healthcare. They aren't paid from healthcare directly. And so when you think about the move towards value-based and how things tend to move quickly, and at some point in the future, you realize that there was some unintended consequences that furthered that chasm of inequity. As we move towards value-based care, we need to, I think, be aware of definitions, those that exist and those that do not exist, and figuring out how to be inclusive in terms of naming and capturing some of these things. So, you know, recognizing we have very different perspectives on this panel. Sharon, one of the ways that I think value-based payment is a success is that it really requires collaboration, right? It really forces that collaboration that we kind of touched upon when we talked about codes. We're thinking about codes because that gives the healthcare organization a way to get paid for grouping folks together and doing something, right? But what value-based payment wants to do is basically that same thing, but for the whole person. It wants to group the different pieces together, pay one thing, and they figure out amongst themselves who gets what for what. How do we even begin to figure out definitions for things like that when the partners vary by state in terms of how you call a social worker this by state and what their standards are? So I'm throwing this stick of dynamite into our panel, but I think that it's a very important point to make up. Like, how do, and I'll start with you, Sharon, because, you know, as the representative of the payer, how do you begin to figure out, okay, first off, these are the organizations we need to partner with, and then just thinking about how complex healthcare is, but how simplistic it needs to be to work well when it comes to the patients that it's trying to serve. just kind of talk about some of the successes, some of the difficulties that you've experienced in your work, or that you know Aetna's experiencing in terms of trying to do that. Let's build this code construct, but in the space of the entire health system, and do this value-based payment.
I'm unmuted, right? Okay. So, I'll just start real briefly by saying, I do agree that, at first it has to be, this commonality of us all coming together and understanding, same definition, same understanding, same place. And I think that, for me, I think is the first point of, I'm going to just say confusion. And I think from even where I sit, and I'm not in that area of value-based, that's not my area of the company, but I will say, I think that that's what's made it really challenging. And so I understandably can't really speak to it, but I would say I understand it enough to know that, it's a commonality of us all coming together, but we haven't made much movement. And I look at it and say, the reason that we probably haven't is because of the complications of the system. That's my feeling, as somebody who's on the inside. And I don't know if others feel the same,
Oriel, if I could jump in here, I would agree with you, Sharon. Like, everyone across the healthcare continuum, we have to kind of come together to solve for this issue. We really have to figure out a way, a common definition of like what value means to us, right? Come to an agreement on what constitutes value, and what are the tools to really determine what that value is. We think about this a lot, especially with the use of value assessment tools that different states are using to inform their healthcare decision-making, and thinking about how those tools, whether or not they do take into account drivers of health disparities or social determinants of health. And we know that there hasn't been, a whole bunch of overlap in those tools, thinking about those issues as well, or folding those into those as well. But we also know that, value assessment can really play a foundational role in facilitating, value-based care by providing a framework to be able to evaluate and, render decisions that are based on evidence, real world evidence, on the outcomes of care, relative to the cost. And so I think there's an opportunity here for us to kind of get at that nitty gritty. How do we define value? What are the tools that we're using to assess it? And are those tools, within that definition and the strategies and the tactics that we use, ultimately moving the needle on disparity?
Can I venture in here? Kind of pulling us back to the whole technology piece. We have had for years electronic medical records, electronic health records that have been so underutilized in terms of providing real tools for clinicians in decision support. What should they prescribe? What's a good regimen? That type of thing. That I think that in an ideal world, you would have the ability to have a number of clinicians prescribing different regimens for different types of patients. And then you could begin to stratify what patients did well with that particular regimen. But then it comes back to the whole outcomes thing. So that now you've almost got a template that would give clinicians a choice, saying, if this is the type of patient and this is the situation, it becomes almost a good practices that health systems could use. I mean, I'm talking in a very abstract way, but it's this whole idea of closing the loop. This is what I think works. Let's try it. This is what the outcome was. This is how much money we saved. This is what the value of that was, with the understanding that every patient is going to require a high level of personalized care. But I think when you've got enough patients into the database, you can start seeing what's going to work. And I wonder if, going back to the whole ICD codes of social determinants, right now they're throwing in the clinical data. And maybe it would be interesting to fold in the social determinant data to start really stratifying. These are patients that not only need this medication or this type of approach, but these are the other aspects of care that we need to be prescribing with them, whether this is social services or whatever that might be. Does that make sense? I mean, all of a sudden, we've got the ability to do this. It's just nobody's ever sat down, and I guess nobody's ever put a potential profit number next to it to make it work. But we've got the ability to do that, to begin to really start looking at various populations and looking at what their situations are and looking at the interventions that work the best in those populations. Then you can start to look at it and say, yeah, that's worth the money. Or we didn't need to do that because we didn't get any bang for the buck when we did this. But if we did these 3 things, we got a real bang for the buck. And, again, I'm a simple man, but that's, to me, is where I think the technology needs to go.
Well, I mean, I think that, somehow the conversations have to happen more in this place, because the more we talk about wanting to get to better outcomes, I think that this is a critical piece of it that's needed, for us to get there. And I mean, that's always been my vantage point, that this is a missing link in it, because we're wanting to do it, but we need, we need the physicians and the patient and all to do it, but we need this component to help drive us there, right? So.
Yep. Now, it has to be healthcare system driven. Yeah. We can't just include the patient and the physician, because we're missing the big piece that pulls it all together.
That's right.
Absolutely. That's the point that I wanted to jump in and make there. It's, to me, one of the things that you all said was we have to come together. The we is coming from, I'm a lowly civil servant, but the we is the industry, right? The gears of the industry that's saying we're going to have to come together. What incentives does the industry need aside from recognizing that social determinants and health inequities are the primary drivers of healthcare costs in the United States? And then also beyond that, you're talking about, for example, electronic health records, Chris mentioned. On the one hand, that's great, but you had a lot of pushback from clinicians saying that it was time consuming, it was burdensome. And so now we're in this era of deregulation and reducing the amount of clinician paperwork. Then we would add then the need to capture things that most of these medical clinicians are not trained to identify and or capture in hopefully a uniform way. But all premised on the ability of folks to feel comfortable enough to trust the person that they're giving this information to. So one of the things that I want to kind of throw in as we start looking at the end of our time here, historically, particularly for minorities and marginalized communities, as are the focus of NMQF, that trust factor has been the seesaw of it all. And your data is only as good as your data is good. And so if you have a system and you have a situation where COVID is a perfect example, COVID with all its unknown and unknown consequences and sequelae and disease states and all that fancy stuff that doctors would say, we have no idea what it means in terms of being a pre-existing condition now. We have no idea if people are going to feel comfortable disclosing it. We have no idea if people are disclosing all the different things that we know matter to their health care. We have no idea, for example, how the recognition of food insecurity will have bearing on how people feel comfortable talking about it. Because there are just so many different stigma attached to all of these different aspects that are associated with social risk. And so I guess as we come up to the time, and I'm trying to be a good moderator and get us back on track here with the schedule. As you consider like your closing statements around data, what we need to ensure access for marginalized communities, to ensure that the capture of data is faithful to their needs. And then once we have data, it doesn't do what we've seen in a lot of the clinical algorithms that the New England Journal of Medicine has reported on, and our chairman, Neil, has written a series of letters about, looking at we see this. So along the lines of what Chris was saying, we see these things because we've put this system together, this clinical tool together, and we see this, and this together equals that. And these algorithms will add race in it, for example, and that may determine whether there's a delayed access to dialysis and or kidney transplant, or it varies depending on what type of clinical algorithm you're talking about. But there's also the very real inherent implicit bias that's present in anything that we're talking about that's data related. And so I threw another stick of dynamite into your closing comments, but I would just like for you all to wax poetic with your last 2 or so minutes each and just talk about, challenges, but then, if you have a glint of optimism, add that too.
Great. I think I'll take it as a start. That's a great point you brought up. I'm going to kind of hit 2 interesting policy pieces of legislation that I think will be helpful to the conversation. And one will kind of be a little bit more tech focused. The other will be health. So I can do both of my hats justice today. So, we've been talking about how the pandemic has really ushered in an era where we must start to look at things differently. And Chris alluded to it earlier about how there are solutions out there to get people's, some of their health issues in check. One of those issues, suggestions would be in the tech space. We've had a sharp uptick in people working from home, like as I opened up with, learning from home and getting their healthcare from home. And we saw that, CMS has recently relaxed the requirements for Medicare telehealth visits. And these telehealth visits are an important step forward, in our nation. And I really feel that we can use access and affordability challenges to kind of answer some of these issues. And one unique challenge, as you kind of said earlier, Oriel, is with algorithms. You mentioned clinical algorithms. So during the past Congress, there's been a growing concern that algorithmic decision-making may exploit consumers. They may amplify bias. They may even foster discrimination. And this can be a huge issue for communities of color that when they start to use some of these technological tools to access their healthcare. And Congress has taken the first steps in addressing the challenge by introducing the Algorithmic Accountability Act. It's led by my boss, Congresswoman Clark, Senator Cory Booker, and Senator Ron Wyden. And it would really direct the FTC to develop regulations requiring large firms to conduct impact assessments for existing and new high-risk automated decision systems. And as I said, it's a really great first step in addressing some of the healthcare disparities. It's kind of addressing it in a unique way almost. It involves technology. It involves technology that may not be top of mind for a lot of experts out there, but it's really important. And it's outside the traditional conversation in healthcare disparities. The health issue I want to touch on really quickly before I wrap up is step therapy. It really refers to the requirement that an enrollee in the health plan first tries and fails on a certain healthcare regimen by their physician. And there is kind of really trying to address the affordability, the cost aspect, and to kind of make that cost a little bit more attainable for the patient. But it's really trying to reduce the financial burden for the patient and provide more cost-effective drugs. So there are certain instances where these patients, may need to bypass certain step therapies to make sure that, that protocol will not hinder that physician's decision. And a congressional solution on that front would be, it came from Congressman Raul Ruiz. He's the resident doctor on energy and commerce. And he introduced the Safe Step Act, which really tried to establish guidelines to prevent the inappropriate use of step therapy in employer-sponsored health plans. And it creates a process for patients to really work with their physicians to seek out these exceptions. And an additional issue in that frame is transparency in that step therapy. So we can kind of start to capture that data, as we've been talking about, to really report on the approvals and denials of step therapy exemptions. So I think that's really an issue that could be addressed in legislation. And although, that's one piece of legislation out there that's being considered, we're still limited on the data around step therapy, drug spending, and patient access. And we really need to kind of focus this on communities of color and how is step therapy impacting communities of color, their access and affordability to these drugs. And my boss has also called for a report on the issue. So I'm really excited to kind of share that, with the public soon. So that's just two different bills that I think are very interesting on the topic, because we need to make sure that we're ensuring like equitable healthcare systems. And it's not a really easy task. So I think that's like one tech kind of a solution for this and one kind of healthcare focus. So I'm really interested in seeing where we can go from here and to hear the rest of the closing responses from our panel. You're muted, Oriel.
Thank you. Why don't we go with Sharon?
Yep, I think that, being able to work at getting, to me, I think it's standardizing our data. The collection of race and ethnicity data, I think is just paramount to most of the work that we're doing. Within Aetna and CVS, I know that it came up around what's happening with AI, and that's been in the news. It was in the news, I think, starting mid to last year, and that was something that came through with us. And I know that we, I think, responded that we didn't have that as an issue within our data, and I think that will be something that's going to continue to come up. But I think data, the use of race and ethnicity is going to continue to be an issue. So standardization will be an issue for that. I think coming together, healthcare, community organizations, and partnering is also paramount. We can't do this alone. I think, that was the old way of doing things, whether it's in, how we make decisions around investments, like what we're doing we make investments in housing. It's not just about making investments in housing and affordable housing. It's not, we need to have community partners, because we don't want to just put people in housing anymore. We want to surround them with the services that they may need, right? The same thing around when we're giving people diabetes prevention programs. We don't want to just give them a prevention program. We want to educate them so that they can sustain that program. So, we need to surround people with services. And I think as we go forward with all things that we do, we need to always look around the table and say, who's not here? Mm-hmm. And reach out. And if that person's not here, we need to make sure that we pull them in.
Yeah, Ariel, I would say we've seen now, the old Dr. King's quote that I really like a lot, whatever affects one affects us all indirectly. We have learned that in an incredible way, this year. I think we have a unique opportunity right now with this pandemic and the more public platform and discussion around the disparities, to Sharon's point, to Chris's point, to really dig into more standardized data that informs care, that then informs the treatment and outcomes. And, telehealth has been a major part of how people are receiving their care right now. And states are thinking more about it, but also states are struggling right now, right? They're hard hit. Folks are losing their jobs, their employer-based insurance. They're cycling into our public health programs, and states are feeling the crunch. So I think, again, partnerships are important, now more than ever. What we can do as corporate partners to partner with states is very important, because we've all got to kind of work together again across the continuum to sort of pool the resources and make sure we can try to plug gaps where we can and stand in the gap where we can as well.
Well, all I can say is I agree with everything, all the summaries that you've made. I think that we do have an opportunity here, but I guess my point of optimism is, for the past 25 years, we've been looking at a very, very dark cloud on the horizon, and we've all pretended it's just another storm that's going to blow over. And I think over the past 2 or 3, maybe 5 years, we recognize it's not a storm at all. It's a 50-foot tsunami that's ready to hit the beach. Now, when we're looking at a storm, we're thinking it's going to blow over. When we're looking at a tsunami, we think we need to do something about it. And I think that that is kind of the impetus for everyone, for all the stakeholders, because we will be overwhelmed by the healthcare costs and just the human and economic costs of uncontrolled chronic disease, not just diabetes, but uncontrolled chronic disease. So I'm optimistic because that's all we can do right now. We've got to change what we're doing. We've got to be able to think different ways and start using the technology and the ideas that we all have, but nobody's really been, ready to do it yet. Let's wait another while. We can't wait any longer. So I think the time is now. I think everybody recognizes it now. And I think now we will start seeing some really significant action moving forward. So that's my voice of optimism. The tsunami at 50 feet off the beach.
Now, actually, I'll take it. It's 2020, and I'll take that sign of optimism. I want to acknowledge that we are out of time, unfortunately, but I thank all of the panelists for lending their time to this discussion and also allowing me to blow up the conversation a couple of times this afternoon. Also, thank you to the audience for joining. This is, 2020 format. We appreciate you all sitting still for this length of time, which is very anti-public health. And also, just remember that what you measure is a value statement, and we have to determine as a society what it is that we value. And then I think my point of optimism is we are in no point in human civilization more suited to capture that data and to let the technology run off with it, so long as we inform it with altruistic, intentions. And we recognize that people deserve to be able to live healthy lives. And in as much as we can do that because we've achieved that, through human civilization, we should continue to advocate for that. So thank you to the panelists. Thank you everyone for listening. And, everyone, let's finish 2020 on a high note.
Great. Thank you very much.
Thank you.
Take care.